move to anybody wants to ask any question, you can just type in the chat box or raise your hand and I'll unmute you. And then we can go to the second case. Dr. Zainab, today you are the NTB expert.
So just before that, I just wanted to ask Dr. Adnan, usually we have seen that as far as temozolomide is concerned, there are some patients who are visiting various oncologists. They come to us and are referring about the different trade names of temozolomide. Would you like to comment on that if there is any preference you have specifically for a brand?
That's $1 billion question. That is my dilemma, daily dilemma. When a patient comes back, practically there is no way for me to figure out because there is so much variation even within the same brand. So these drugs are not controlled. So say for instance, if I am getting Everest temozolomide, which is coming through proper channel, I'm also seeing Everest temozolomide, which is coming through gray channel. And it is the drugs that are coming through gray channel that can be faulty. So, in fact, most of our experience with temozolomide when we started was only one brand, and that was very early when there weren't so many copies. And then that we saw no difference. We have been trying to publish that data where we looked at the outcome of GBM after using that particular brand. So there was no difference, but now that brand is also not available and it's patchy. So the problem is that these drugs you cannot count on any one particular brand because both forms are available. When a patient can afford, I always tell them to buy from a source which is registered and it's coming through proper channel. If a patient cannot afford, then unfortunately, whatever they take, I don't make it more difficult for them because they're already challenged.
Right.
Yes, thank you.
Okay, then now we can go to the second case.
Right. So the second case is of 44 years old lady who presented with complaints of lower back pain for last 2 years, and recently for last about few months she also started having lower limb weakness to the point that she was almost bedbound and with recently loss of sphincters as well. We got an MRI done. The MRI shows a sacrococcygeal mass. The patient was advised a CT guided biopsy outside AQH, for which she underwent on June 22nd, 2022. Histopathology was chordoma. After the biopsy, patient was referred for radiotherapy. She received 30 fractions during July to August of 2023.
Dr. Shumaila.
So as we already know that this is a biopsy-proven case of chordoma, we can appreciate that there is a large heterogeneous abnormal signal intensity area centered in the pelvis involving sacrum. It has an associated soft tissue component which is showing extension in along close to bilateral iliac joints, and probably there is some intrapelvic extension as well. If I can see the axial images. Go back to the previous slide as well, the sagittal as well. Yes, there is a large intrapelvic soft tissue component, which is displacing the internal pelvic organs. And I can appreciate that this is probably infiltrating the bladder base because I can see hydronephroureter even in the third image on this and even in the previous images, which were T2 corner. So there is probably some bladder base infiltration as well. It is hypointense on T1 weighted images. On the right side, I can see that adjacent to bladder, there is a soft tissue component extending. It is extending in the pelvic muscles. So it is an extensive recurrent mass, probably a residual mass because only the biopsy was taken. So Do we have a plain X-ray film as well?
Sorry, Dr. Shumaila,
Do
what
we
do you?
have an X-ray film to of this patient as well?
X-ray, I think we do not have.
No,
Okay,
Right,
right.
Zainab? We don't have X-ray.
no, we don't have it.
Right.
Okay.
So you wanted to see the X-ray, Dr. Shumaila, to see whether it's light take or it's
Yeah, because whenever we are reporting bone tumors, it is important to have a plain X-ray film for cortical details and for involvement of the bones.
right.
Plus, we do not have a T1 plain sagittal image. I would recommend that next time if you have any uh, lesion related to bones, it is good to have a T1 weighted plane image, because on T1 plane we can comment on the marrow and involvement of rest of the bony structures. We
Okay.
don't have a T1 sagittal for rest of
Right.
the vertebra. Yeah,
I think we do not have here
no, we
because
do not.
yeah.
Yeah,
Dr. Shumaya, the MRI was done outside the QS, so we just had
okay,
some
Limited, yeah. So,
okay.
but it's like, but it's I would say quite invasive and the widespread
Yeah,
disease.
because we already have a biopsy, so MR is basically to see the extent and involvement of different structures so that we can give a surgical guide map.
Right. So, really, when we look at the chordoma, we think about the surgery because, it's a surgical disease. But with this extensive disease, I think, in my opinion, if I'll tell you, there is no surgical cure for this. So that's why we wanted to discuss this case. What options do we have in our country or in our region, maybe, for such patients? Do we have targeted therapy available? Do we have any other recommendation for the radiation? Dr. Adnan.
I'm sorry, Yasin. What was your question once again?
Sorry, so I was saying that this chordoma is quite extensive, and surgically we and I don't think that we can take it out like everything, and so we will need something to control somehow. Do we have any targeted therapy available for such patients, or we don't have enough data to support any? Um,
Um, Personally, when you look at it, yes, they say that the most common drugs that are being used is imatinib, Gleevec, or perhaps adriamycin. Personally, I have not experienced that many cases where I have tried these to tell you how my personal experience has been. Perhaps maybe, excuse me. Um, but personally, I haven't used these drugs because I haven't seen too many patients coming to me with this. But yes, if you look at literature, doxorubicin, imatinib have been recommended in cases like these where you get stuck and you have a very large area to cover, and radiation and surgery probably cannot go that far. So there are
right.
systemic options.
Okay, and Dr. Mazhar.
Yeah, certainly. In this case, I mean, nowadays with conformal radiotherapy and all that, we can radiation is definitely would be indicated, but I have no experience of any immunotherapy or chemotherapy in this case. Um, the only option I think is surgery and radiation. And in this particular case, it's a long history. So in her case, I think as much as surgery could remove that has been done, and then she has been radiated, and that's all what you can offer. Her performance, I don't think would be great because she's bedbound. So I don't think we should give anything that can give her more side effects without any proper data. I think the best supportive care for this patient is the only recommendation.
So, in this case, you think a surgical debulking and then radiation should be considered, right?
Yeah, then that's all. Two things. If surgery can be done, as much as a tumor can be removed, that's the without causing any extra side effects to the patient from surgery or from radiation. Because she already, in this particular case, the history is almost 2 years, and she has lost power in the limbs. She has lost sphincter controls, so the damage has been done. And I don't think if the we could sort of reverse this process. But
Yeah.
the only thing that it has been done is right. Like she has had surgery done and then radiation has been given. And after that, there is no scope for further radiotherapy in that area because 30 fractions mean radical dose, so 60 grade that she has received there. So after this, I think she would need best supportive care.
Right.
I wouldn't. I mean, I totally agree with Dr. Mazhar, but again, there is always room for trying drugs like imatinib. It always depends. Yes, she's bedbound, but how mentally intact is this patient? She's bedbound because of the disease itself, but if she's mentally intact and she is full of life over there, there's no harm in trying things like imatinib. There have been phase 2 trials where it says that it holds the tumor for some time, but then again, don't give false hopes to the patient, and we should be very realistic what we are trying to achieve. If this patient is coming from a small town, from they hardly have money to come, then yes, certainly don't do anything. But it's from a family who's taking care. They have two caregivers, morning, evening, taking care of them. Then I would certainly try something like what has been reported, to see if it gives some more, keep her pain free, prevent these things from moving forward.
Right. So it's palliative intent and then right. Perfect. Okay, sir. Thank you. Any questions from our panelists? I can only see here the neurosurgeon that I recognize is Dr. Mehboob. If he wants to add something, you're most welcome, sir. And Assalamu alaikum. Just a minute. Yes, now we can hear you.
Thank you, Dr. Hassan. It's a long time we are hearing about this tumor board, but we are attending this for the first time because we have started our residency program here.
Nice.
So next to me is Dr. Swail, who is assistant professor in neurosurgery with me, and
Great.
next to him is Dr. Haris, who is my resident. So
Great.
hopefully,
Welcome, sir. Welcome. आप
and
अपने cases भी ला सकते हैं, so we always advertise like 1 or 2 weeks before, so that if you have any case, you can also send us, and then we will
yes,
discuss.
we will definitely do that whenever we have any case, even a simpler case, we will be discussing
Yeah,
that,
yeah,
and hope that we continue doing that. And regarding these cases, I think that the panel has definitely given us a definite plan,
right.
so nothing much to say about that.
Thank you, sir. Thank you very much. Okay.
Thank you.
So if we don't have any further comments or questions, so that we only had 2 cases. Thank you so much for joining us. It was very interesting discussion.
Thank
And
you.
see you all, inshallah, next month.